prefers to this position. I know you say it's kneel standing. So want you to make sure that you know these are the contraindications for this position. Will be one of the questions. So we should not use this position for patients with rheumatoid arthritis, osteoarthritis, okay, severe ones, and also a patient with recent surgeries or a patient having knee joint instability. Okay, so this should not be used for those people at all. Okay, so make sure that you know the contraindications for this position. Then we need to move our patient from quadruped position or from sitting, heel sitting, okay, to the kneeling. So you guys remember we had our patient before in quadruped position, right? From the quadruped position, I may have a small ball underneath here, the patient, okay, and ask them to be just sitting on that ball. So this would be the position, okay? And from there, we're gonna start moving to kneel standing, okay? I may have my patient in this position, okay, sitting on a heel, and I would be in front. And the same as we did, protect the shoulder, okay, and start at the glutes, facilitate them, and get the patient into this position. Okay, so if anyone wants to volunteer, we could finish kneeling and all the stuff in it, all the interventions. Anyone? So could be the starting position, okay? Or it could be the quadruped, going into the heels, all right? And from there, would start help the patient if they are not able to do it, okay? So I'm gonna be in front of my patient, okay? Protect the affected shoulder. Again, this shoulder should be on this arm should be in my shoulders. Okay, and my hands is gonna be on the glutes again, all right? If you need it to hold the affected side, it's gonna be there. So for him to lean forward a little bit, that would be helpful. But the leaning should always be at the hips, not at the trunk, okay? So the patient is leaning forward the hips, okay? I can facilitate them at the glutes and trying to go into a kneeling position. So here is the position. We end up here. Okay? So in this position, all right, this is the affected side. This is the less affected, I'm sorry. Okay? I'm gonna be on the side of the patient here. Okay? Once the patient is in this position, we're gonna work on stabilization in here. I actually need him to be in a good base of support like what Nathan have now, right? Good base of support first, and then start applying stabilization techniques. So I can do rhythmic stabilization for him, okay? Hold your body, don't let me move you. Okay? And here, hold your body, don't let me move you. I can do it shoulder against pelvis. So here, and hold your body, don't let me move you. All right? Change your position, switch forward and backward, hold, don't let me move you. Okay? This can be done on the other side. I can do alternative isometrics. So hold, don't let me move you. More. He's not able to hold this. So stability of this position is more forward or backward. If I push him this way, he's great at this, right? So stability of this position is actually more posterior because he got the base of support posterior, not anterior. Make sense? Okay. Here again, we did the alternative isometrics, stabilization reversals. Look, he's not getting it. So it's easy for them to fall forward. So this position is more stable posterior. You can do it side to side. Here, there. Okay? We can do some controlled mobility stuff. Like what? Like weight shift. So shifting to the less affected, shifting to the affected. Okay, so this is the shift, weight shift that could be done. Okay, you can resist this weight shift, correct? So resistance to shifting the weight to the left. Okay, go, keep going. Dynamic reversals. And move towards my body now. Okay, so here is dynamic reversals for weight shift towards the affected side. Okay, then the other side. In this position also, the patient may have their arms in front of them. So the COG is now moved forward, correct? You can resist this movement, both directions. And here, all this activates the core muscles, correct? Okay, so again, movement of the extremities, okay, can be resisted. This patient can reach things in front of them, right? This patient also can move one leg in front of the other. So staggering, okay, or kind of have one foot in front of the other, changing the base of support, and you apply the things again, right? So you can apply this, you can apply all the stuff. You can resist at the pelvis, here, right? Here, in this position. Then you have the other leg forward. So we do both. Affected side forward, non-affected side forward. You do that kind of stabilization in this position too. Again, you change, you have the arms forward and you start doing resisted movement, flexion, extension, okay? You can do the PNF this direction and down. So a lot of things could be done in this position, right? But again, this position is required as one of those positions that we need for recovery from falling. Okay? You can work on this patient who are not having good quads, because right now they are not using their quad. They're mainly using the hip stability, correct? So quads are not needed here. So a patient with weakness there, okay, I could train them in this position before transition standing. All right? Good. So these are the things that could be done there. And then we're gonna move to half kneel.